the Office of Community Outreach and Engagement at Karmanos Cancer Institute, I'd like to welcome you to tonight's community conversation on cancer event. Both those joining.
محاورات
Quiero darle la
عن
bienvenida.
سرطان
My name is Ali Faki, and I'm honored to be opening this important gathering. The purpose of this series is to connect our community with our science and our science to our community. These conversations are a space to share knowledge, listen deeply, and build stronger connections between our researchers, providers, and the communities they serve. We are proud to be partnering with the Detroit Public Library on this entire series, and we thank them for their ongoing collaboration and support. Yep. We also want to recognize our wonderful community partners who are in the back joining us today. Cancer Thrivers Network, Corktown Health, Healthier Black Elders, Michigan Ovarian Cancer Alliance, National Council of Negro Women, New Day Foundation, the Pink Fund, We Run 313, and Western Wayne Family Health Center. Yes. We are also grateful to Global LT for providing translation services in both Arabic and Spanish. If you're joining us online, you can select your preferred language by clicking the interpretation icon or option at the bottom of your Zoom screen. A few quick housekeeping before we get started. For our online audience, we ask that you hold your questions and you use the Q&A feature on Zoom. For those in person, we ask that you hold your questions until the Q&A session at the end. Please note this event is being recorded to help us share and expand the impact of our conversation. For those in person, restrooms are straight out this door and to the right. Finally, I'd like to thank our speakers, Dr. Kevin Ginsberg, who unfortunately will not be able to join us tonight due to an unexpected surgery, and Dr. Frank Kakowski for joining us tonight, and our three moderators, Lance Woods, Stephen Duet, Lossie Pearson, for guiding this important conversation. I will now hand it over to our moderators to introduce themselves.
Good evening, everyone.
Good evening.
My name is Lossie Pearson. I am a lay health advisor, and I will be here acting as one of the moderators this evening. I hope you learn a lot and enjoy.
Good evening, everybody. Or we in Detroit, so I like to say, what up, though? I'm a proud Detroiter, born and raised in this city, educated in this city, K through 12. I graduated from Tennessee State, had the opportunity to go to school there. Graduated with a degree in business, concentrated in supply chain management. And Detroit pulls on my heartstrings. My family is here, pulled me back to Detroit, where my passion is community development. So I am the co-founder of We Run 313, which is Detroit's premier running club, one of the largest run clubs in the nation and in the world, where we connect like-minded individuals through running to build a healthy and happy community. This topic in particular is very near and dear to my heart because this cancer has plagued my family for generations. My dad and my uncle is actually on the Zoom call, so I'm sure they'll be tuning in to answer some questions, well, ask some questions. So I'm one of the moderators and looking forward to learning from Dr. Kakowski.
Good evening. My name's Steve DeWitt. I graduated from Wayne State's medical school in 1978 and then spent 4 years here at Wayne State in the internal medicine residency program and stayed on as an active staff member at initially Hutzel and then at Harper Hospital. I went into private practice and had to suddenly retire in December of 2020 when I was diagnosed with acute myeloid leukemia. I chose to be treated at Karmanos Cancer Institute as it is one of about 50 comprehensive cancer treatment hospitals in the country. My induction chemotherapy began on Christmas Eve, and 2 months later, when I was, by the time which I would recovered, I was in remission, and my bone marrow was as acceptable counts. I was given a stem cell transplant, spending 3 weeks in the hospital. I was a participant in 3 clinical trials, during my treatment period, and I'm about to start a fourth one in the next couple of weeks. I remain in remission from my AML, but I've suffered a complication that requires frequent treatments at Karmanos, including I was just spent about 6 hours there today. I'm a member of the Karmanos Patient Advocacy Program, and I also do volunteer work at Karmanos under the guidance of the chaplain, Father Luke. Thank you. So now you should have all received this a little packet here with 2 sheets of paper, pre-knowledge questions. And for those of you attending virtually, I think they're available online. So before we dive into the topic, let's start with a few quick questions to see what we already know or think about this subject. Don't worry, nobody gets a grade. This will help us connect what we are about to learn with what we already understand. So there's a white sheet of paper, fill it out with the 3 short questions, tear off that sheet, and somebody should be coming around to pick it up. For participants joining via Zoom, the poll will be launching on your screen with the same 3 questions. Answer them using your device, and thank all of you for your participation.
It's actually 6 questions, so there is a back to the white sheet as well.
All right, at this time, I'm going to introduce our keynote speaker and presenter, Dr. Frank Kukowski, who holds an MD and a PhD, is a member of the genitourinary multidisciplinary team, that's a tongue twister, leader of the Karmanos Cancer Institute Translational Molecular Conference, and assistant professor, clinical scholar track at the Barbara Ann Karmanos Cancer Institute and Wayne State University School of Medicine. He is also a scientific member of the Molecular Therapeutics Program. Additionally, he conducts clinical and translational research trials in genitourinary oncology. Dr. Kukowski is a member in good standing of the American Society of Clinical Oncology and the American Association for Cancer Research. He is a past recipient of the Department of Defense Prostate Cancer Research Program Physician Research Award and the Prostate Cancer Foundation Young Investigator Award. Dr. Kukowski has authored 20 publications and 8 review articles and is principal and co-investigator on 3 grants. With a focus on the overlapping concepts of plasticity, dormancy, and quiescence in prostate cancer, he uses patient samples, cell structure, cell culture, animal models, and bioinformatics to understand this biology and develop ways to prevent relapse, deepen treatment responses, and combat treatment resistance. Dr. Kukowski has presented lectures for several courses at Wayne State University, including clinical and molecular aspects of cancer and principles in translation and clinical cancer research. He is a mentor and fellows and graduate students. Without further ado, let's give a warm welcome to Dr. Kukowski.
Well, thank you all. So I'm doing double duty tonight, as you mentioned. We were going to have 2 speakers, but my friend Dr. Ginsberg is stuck in the operating room. Want to be clear, he's on the easier side of the scalpel, so to speak, as a surgeon rather than the patient. It's going fine. He just, there was a traffic jam and his cases got delayed. So I'm going to cover both the topics that he was going to cover and the topics that I was going to cover. So Dr. Ginsburg was planning to cover screening and diagnosis of prostate cancer. So that'll be the first half. And I was planning to cover treatment of prostate cancer. So that'll be the second half. But unfortunately, it's going to be all with me. Okay. So getting into screening and diagnosis of prostate cancer. For the first half, we'll go over, the things we're going to learn. Who gets prostate cancer, what the symptoms are, how we screen for prostate cancer, and recommendations for screening, and when you should see a doctor, either a generalist or a specialist for prostate cancer. We have a little bit of a urologic humor here. Mr. Potato Head. Yeah. Us urologists and urologic medical oncologists would like to keep it light-spirited. Yet, so, boy parts are funny. What can I say? So Dr. Ginsburg, he's a urologist, so that's specializes in the urinary tract and men's health, some women's health stuff as well. But so he's a surgical specialty, and I'm a medical oncologist, but I treat, so chemo doctor, you might say, but I treat mostly urologic stuff. Okay, so what is the prostate? Probably not everybody knows, so we'll start there. So prostate gland is a gland that's normal function is for secreting nutrients into the seminal fluid, so a part of the male reproductive tract. And it's situated right at the bottom of the bladder, and it surrounds the urethra. So that's important both for diagnosing prostate cancer and the symptoms that it might cause. So for example, it might cause urinary symptoms. Prostate cancer in general, it is really common. Something like 1 in 6 men are going to get prostate cancer. Now, not all those cases are severe, not all of them are aggressive, not all of them need to be treated. Sometimes we can get by with observing, but it is very common. Special interest to us in Detroit here, it's more common and probably more severe in men of African descent. About 51% higher among Black men. A lot of reasons for that, both genetic, societal, and socioeconomic. But beyond the scope of what we're trying to discuss today, but even if you look in Africa, there are differences that it carried over with the genetic ancestry. So who gets prostate cancer? Men, of course, usually older men, but really, you hardly ever see it in somebody in the 30s. Usually not in somebody in their 40s, but it's not. We have had patients in their 40s, rarely in their 30s, but mostly men as they get older. The peak age for diagnosis is in the 60s. Symptoms. The trouble with it is oftentimes it's nothing at all. Sometimes there are urinary symptoms because, as we said, it surrounds the urethra and can push on things. But difficulty urinating is not necessarily a symptom of cancer. Usually it's not a symptom of cancer. As guys get older, just normally the prostate gets bigger in a benign fashion. So non-cancerous, we call that benign prostatic hypertrophy, pushes on the urethra, have trouble peeing, the weakened urinary stream, trouble starting the stream. That's usually not cancer. So you're showing there, large prostate, usually that's benign, but prostate cancer could do the same thing and push on the urethra and have people have difficulty with urination. Okay, so Dr. Ginsburg's definition as it relates to prostate cancer screening. So screening, it's trying to find a disease when it's earlier and easier to treat, and find a disease when you can still treat it. So this is doing things, testing, for people that aren't known to have cancer to try to find it earlier. And it's a complex area and a very important area in prostate cancer. Really, there's two things we have for prostate cancer screening. The biggest thing or most commonly done thing is the PSA blood test. We'll describe what that is. And then part of that can be a digital rectal exam. As you saw earlier with the anatomic diagram, you might notice the prostate is right next to the rectum, so it can be felt by a rectal exam. Okay, so the famous PSA prostate blood test. So PSA itself stands for prostate-specific antigen. It's a protein. It's made and secreted by the prostate and prostate cancer. So all men who have a prostate are going to have some amount of PSA. But if it gets higher, then the risk of prostate cancer being there is greater. So, of course, we didn't always have the PSA blood test. We didn't always have that as available for screening. And before then, before we had PSA, and it came around in the late 80s, prostate cancer was worse. So about a third of the men with prostate cancer died of prostate cancer, and about a third of the men that had prostate cancer diagnosed presented when it was advanced and couldn't be cured. So there are a lot of advantages of using a PSA test for screening. And it detects cancer earlier, maybe even more than a decade earlier before it might have presented itself and otherwise been apparent. Cancers that we find by screening, they're more likely to be localized, more likely to be cured if they are treated. So when we started PSA screening, for prostate cancer, the number of cases that were diagnosed when they were metastatic drastically decreased. And curiously enough, we actually didn't see the same thing for breast cancer, but in the blue line there, so PSA testing came along in the late 80s. Really, we had a big decrease in the number of cases that were diagnosed when they were advanced and no longer curable. So those are good things, but there's been some controversy, justifiably so, with PSA testing. So it's a good thing we find high-risk disease, but we can also find low-risk disease. And one of the problems with prostate cancer is not all those cases are going to be aggressive. Not all those men are going to end up having problems from the prostate cancer. So screening is not always a good thing. It could cause harm. So from the testing itself or from overtreating a disease that wouldn't have caused trouble, it could cause harm. So side effects. And so we'll get into a little bit later more, but the side effects mostly for treatment of localized prostate cancer are urinary or sexual in nature, either trouble controlling urine or trouble with erections. So this was getting into, so in my life period here, so PSA testing came along when I was a little kid, and here we're getting into like the beginning of my medical career, about 2012 or 13. This controversy really came to light that there was a recommendation that came out from the U.S. Preventive Services Task Force that we do very little PSA screening. And it was a lot of press, and then they kind of walked that back a little bit. So the pendulum swung that way, and it's come back a little bit in recent years. So where we are right now. I think we're doing a lot better than we were many years ago. And this is my opinion. I think we're probably under-screening a little bit, but we're doing less over-treatment of indolent prostate cancer. So we're trying to maximize the good things, treating prostate cancers that are likely to cause trouble, and trying to minimize treating prostate cancers that are less likely to cause trouble. So recommendations. So is prostate cancer screening right for you? It may be. So in overall, we want to screen people that are likely to get benefit out of the screening. So somebody who's very old or very sick, not likely to get the benefit out of screening because they have to live enough years to have that make an effect on their life. But so overall, we want to screen people who are pretty healthy and going to live about 10 years or longer. That's going to vary, not just with age, but other health problems. So there's several guidelines out there. We tend to go here by the American Urological Association guidelines. In general, begin screening either with PSA or PSA plus rectal exam at between 45 and 50 for a general population, all comers, but earlier, maybe age 40 for higher risk. And as we said, Black men have higher risk of prostate cancer. So for Black men, probably screen earlier. Also higher risk, a strong family history. And part of that is genes that we know about, such as the BRCA genes, and some of it is genes that we don't yet know about, just that have come through in family history without a known gene alteration. So screening, typically, that means PSA about every 2 years, with or without digital rectal exam. The digital rectal exam adds some, but it's probably better to get some screening rather than nothing at all. And usually we stop around age 70. So that's something a little bit controversial perhaps, and it's going to vary on the patient and how healthy they are. Not all 70-year-olds are the same. One of the problems with PSA screening is there's not a clear definition of what a bad PSA is. So if we had to pick one, would say above about 4 nanograms per milliliter is concerning, but there's going to be overlap. So because PSA is made by both normal prostate and prostate cancer. So if you have a big normal prostate, PSA might be high without prostate cancer being there. Or conversely, if you have a small prostate, but there's some prostate cancer there, it may be not that high. So for example, with that threshold of about 4, 25% of men with a PSA greater than 4 is going to have prostate cancer. So far from everybody. And there are other reasons that PSA can go up. So the big prostate, like I mentioned, but infections, including urinary tract infections, prostatitis, any procedures on the prostate, like having a urinary catheter placed, maybe with sexual intercourse and ejaculation, bike riding, maybe, and prostate cancer itself. So if you have an elevated PSA, say you go to your primary care doctor, they check your PSA, it's a little bit above 4, what should you do? Don't panic. Sometimes it's going to return to normal. But you should repeat it. If it's still elevated, then you may want to have things looked at further. So that usually means seeing a urologist, so a doctor who has the ability to look into that further and do a biopsy if you need to. Okay, so if you have a high PSA, talk to your doctor about your health. Like for example, if there's a lot of other health problems going on, maybe it doesn't make a whole lot of sense to look into it. But and decide if you should have more evaluation into it. So those tests could be, it could be imaging. Oftentimes that's an MRI. Especially in the past 5-10 years, we do a lot of MRIs of the prostate. They give a really good description of the anatomy. Could be urine tests, especially looking for a urinary tract infection. And then if there's still concern, maybe that warrants a biopsy of the prostate. So prostate biopsy, so that's taking a piece of the prostate tissue with a needle. That's really the only way to for sure diagnose prostate cancer. Overall, PSA has really changed how we approach prostate cancer, both screening and also treatment, and it saves lives. So overall, for average risk people, talk about screening in the late 40s, earlier 40s if you're at higher risk, and maybe stop at age 40, but depends on overall health. So maybe, do you want to pause there or go into the second half? Keep going? Okay. Okay, so that was screening. That's what Dr. Ginsburg was going to talk to us about. And I was going to talk about treatment. So treatment, all stages, both localized, indolent, localized, more aggressive, and metastatic or advanced diseases. Okay, I don't have any disclosures. So from the second half of the talk, what we're going to discuss, why we need to treat prostate cancer, and try to pick which of those prostate cancers require treatment, and then talk about, in basic terms, how we treat both localized and metastatic prostate cancer. A little bit of repeated epidemiology, but it's worth repeating, I think. So it's very common. about 300,000 new cases a year. It kills about 35,000 men a year in the United States. All stages combined, the survival is quite good, but not as good for advanced stages. It's important because it still, even though it made progress, it still kills a lot of men. So this is death from cancers in men in the United States over the past about almost 90 years. So the biggest lump there is lung cancer. And as an aside, so that kind of rose after smoking became more common in the 19 teens and 20s. So that's that big blue line. But the second highest line there in gray is prostate cancer. And so getting back to the PSA testing, after the PSA was approved in the late 80s, it made a lot of progress. Yeah, maybe not actually as much progress in the past couple years as in the 10 years before that. Again, repeating, but I think it's worth it. So, African Americans, men of African descent, tend to do worse with prostate cancer. Lots of reasons: genetics, societal, health system. They tend to present with more prostate cancer earlier and higher stage. They tend to get less intense treatment. But if Black men get the same treatment, they seem to do as well, perhaps even a little better than other races with prostate cancer. So some of those things is just treating as aggressively as is indicated. Part of that can be being on clinical trials, and if we adjust, if we kind of look at big numbers of people and we say adjust for socioeconomic status, some of that disparity dissipates, but not all of it. That's not the only thing. But we are doing a little bit better over time. Okay, so let's get into which cancers should be treated. So firstly, as we discussed a little bit, if there's a bigger medical problem, maybe that prostate cancer shouldn't be treated. So that kind of depends on how severe the prostate cancer is and how severe the other medical problem is. So some patients with localized prostate cancer should be treated. Some patients with localized prostate cancer should not be treated, depending on how high risk the disease is and their other health. Almost all patients with metastatic prostate cancer should be treated, unless there's a really big other medical problem that's going to be more limiting. Okay, so localized prostate cancer. Bring up our anatomic diagrams again. So the prostate there, next to the rectum, below the bladder. So localized means confined within the prostate gland. So which localized cases should be treated? A lot of things go into that. Basically, we're trying to assess how likely it is to cause trouble. Either symptoms, urinary tract, or spread, and even be more dangerous if it spreads elsewhere. So that includes physical exam, the PSA, because the PSA correlates somewhat with how much cancer there is. Imaging, sometimes at MRI, sometimes CT, and the biopsy results. And the biopsy results is a big thing. And that gets into this kind of confusing concept called the Gleason score. So Gleason, comes from Dr. Gleason, several decades ago came up with this grading system. It's not quite as complicated as it seems, but so basically the Gleason score is just the way that we give a grade to prostate cancer. And almost all cancers have grades. And grade is not like A, B, C, D, F, but in terms of like how abnormal does it look? If it looks like almost like normal tissue, that's low grade. If it looks like messed up, it doesn't look anything like a prostate at all, that's high grade. So Dr. Gleason, God rest his soul, so he came up with these patterns of looking at stuff under the microscope. The pattern 1 and 2 we hardly ever bother with anymore. So basically, to make things more complex, we don't bother with 1 and 2, so we're starting off at 3, and we take the most common and the second most common pattern and put them together, and that gives that Gleason score. So for example, if the whole sample on the biopsy is 3, then that's 3 plus, we say 3 plus 3 is 6. It's not exactly the same thing as math in that the the first number is a little more important than the second number. So 3 plus 4 is not exactly the same thing as 4 plus 3. It's it's only kind of like math, a little bit like math. Artistic math, maybe, I don't know. But so to try to like make it a little simpler, more intuitive, more commonly today, rather than just the Gleason score, we'll more commonly put them in what we call grade groups. So 1, 2, 3, 4, 5, that's a whole lot more intuitive than a score that goes from 6 to 10, where 7 is not the same thing as 7. So to translate that into grade groups, Gleason 6 is grade group 1, Gleason 7, 3 plus 4 is grade group 2, Gleason 7, 4 plus 3 is grade group 3, Gleason score 8, which is usually 4 plus 4, is grade group 4, and Gleason score 9 or 10, which is 4 plus 5 or 5 plus 4 or 5 plus 5, is grade group 5. Okay, so the Gleason score still very commonly used. Maybe it won't be used 20 to 30 years from now, but it's going to be used for a while at least. And the utility of it is it tells us just how messed up the cancer is. If it's a lot like normal prostate, or if it's nothing like normal prostate, and if it's very little like normal prostate, it's just likely not to behave nicely. So that helps us decide which we treat. And then there's this whole nebulous concept of active surveillance, which is kind of like treatment and kind of isn't. In that, so Gleason 6 prostate cancer, grade group 1, is almost never going to cause trouble unless it transforms into a more aggressive subtype. Okay, we're going to pause here because I think we're due for a change in interpreter, right?
Yes, interpreters, please go ahead and transition now. Okay, we're good. Thank you.
Okay. It's good we did a pause there because before we get on to this confusing thing called active surveillance. So Gleason 6 prostate cancer almost never is going to hurt somebody. It's, it grows, it can cause like a little bit of trouble, maybe some urinary symptoms, but it's hardly ever going to spread and kill people. And if we treat a Gleason 6 prostate cancer, and this is kind of what we got into the whole morass of overtreating prostate cancer decades ago. If we treat a Gleason 6 prostate cancer, we're probably not going to help somebody that much, and we can cause side effects of the treatment, urinary and sexual mostly. So an approach for dealing with Gleason 6 prostate cancer is this concept called active surveillance, where there's set programs. It'll vary a little bit from society to society or practice to practice, but there's set schedules of follow-up to try to catch this before or just as it's transitioning to a more aggressive form, if that happens. It may not transition to a more aggressive form at all, and in that case, we can either totally spare guys the side effects of treatment or delay the side effects of treatment. So active surveillance, a low-grade prostate cancer can be safely managed. And that includes regular exams, PSA checks, could be MRIs, and if there's something concerning on one of those other things, like exam or PSA, there may be a repeat biopsy. If there's a repeat biopsy and goes from Gleason 6 to Gleason 8, then that's a prostate cancer and needs treated. Or if there's something else concerning on exam or imaging. Okay, so if we do decide to treat for localized disease, of course we could spend hours talking about just treatment of localized disease, but mostly treatment is either surgery. The most common surgery is radical prostatectomy or radiation, typically radiation external beam to the whole prostate gland. There's some other more nuanced approaches for lower risk prostate cancer, but mostly this is what we're looking at for treatment of localized disease. They have comparable outcomes. We don't really think one's much better than the other. It's kind of patient choice in terms of what would work better for you. So different things go into it. Both of them have risk of urinary and sexual problems. and then both of them have things that the other one might not have. So of course, radical prostatectomy, that's going to be at least a brief hospital stay. Yeah, it's looking down the road. If the prostate cancer comes back later, it's a little easier to do radiation after surgery than surgery after radiation. With surgery, one of the big pluses for some guys is it doesn't require any androgen deprivation therapy. And we'll get into what that is. But at least for moderate to higher risk prostate cancers, radiation usually, at least is recommended to be given with some androgen deprivation therapy. So for guys that's a big downside, then they may lean more towards surgery than radiation. Okay. So this is what I mostly do for a living is treat advanced prostate cancers. And it's good and it's bad. Prostate cancer, when it really causes problems is because it spreads. So that's either bones, lymph nodes. The bone and lymph nodes are most common. And those lymph nodes could be in the pelvis or distantly. Also can spread to organs such as liver and lung. So metastatic prostate cancer is very treatable. You guys do a lot better with treatment than not with treatment. But at least as of now, it's for practical purposes, it's not curable. There are guys that can go very, very long with treatment, but we kind of hesitate to use that C word. Most of the treatment for metastatic disease is with medicines. They improve symptoms if somebody's having symptoms, and they add years of life expectancy. The centerpiece, for better or for worse, of medical treatment for prostate cancer is androgen deprivation therapy. So prostate cancer will grow faster if it has testosterone. And conversely, it'll shrink, and at least some of the cells will die if it has very little testosterone. So androgen, testosterone being a androgen just a word for male hormones, including testosterone. So taking that away or reducing how much androgens there are is the main way that prostate cancer is treated with medicines. So it's another name for this. It's not the greatest marketing term, frankly, but it's an appropriate term. You might also call this medical castration. Yeah, it's not the best marketing term. Yeah, androgen deprivation therapy. Yeah. Surgical castration could be done, but that's not usually attractive to most people for obvious reasons. So how this works is basically the androgen deprivation therapy keeps the testicles from making most of the testosterone. There's whole dissertations and work into this, but it interferes with the hormonal communication between the pituitary gland, which is the master hormonal regulator at the base of the brain, and the testicles. So it shuts down that communication. Testicles stop making testosterone. Typically, that's given by long-acting depot injections that last, depending on the dose, 1, 3, 4, or 6 months. There is a pill equivalent now, and one's not necessarily better than the other. But for advanced prostate cancer, so either spread in the pelvis or spread distantly, metastatic, usually that's continued indefinitely, as long as it's working, and usually that's combined with other medicines. So kind of the first and most common type of medicine we use for prostate cancer medical treatment is androgen deprivation therapy, one of those drugs, and typically we add drugs to it. So androgen deprivation therapy has side effects. It's what justifiably, understandably gives guys grief about undergoing this. There's going to be side effects. It's usually not a totally life-altering, routine-altering thing. Probably the easiest way to describe the side effects of androgen deprivation is they're a lot like women's menopause. Because it's an analogous thing in that women normally menopause, ovaries shut down, they stop making estrogen. And testosterone does a lot of the same things in a man as estrogen does in a woman. So sometimes we'll say it's andropause. So we're shutting down testosterone production. And so some of my patients, like they come with their wives or sisters, and some of the wives or sisters are like, oh, cry me a river. Welcome to my world. So guys do get stuff like hot flashes, sweats, mood changes, bone loss, over time a little bit increased risk cardiovascular disease, and what gives guys the most angst about this is there's going to be some sexual changes. There's almost always going to be some loss of libido, not always, but sometimes a loss of erectile function. But almost always some loss of interest. And that's just because there's less testosterone. It's not, the drug's doing what it's supposed to do, but we don't like all the things that it's supposed to do.
Yeah.
And then typically, we add drugs to androgen deprivation therapy. So typically, that's going to be that could be an oral anti-androgen, it could be an IV chemotherapy. There's a new radioactive drug called Pluvicto now. For some patients with a class of mutations, it could be a PARP inhibitor, which is a pill. Rarely it's immunotherapy. And then we also give drugs to prevent some of the bone side effects. So just in general, what this often looks like, if a man has metastatic prostate cancer, they'll almost always get androgen deprivation, and we'll add at least one drug to that to start off with. It's going to be either one of the anti-androgen pills. It could be an anti-androgen pill plus an IV chemotherapy drug for a limited course if his disease is higher risk. And how typically, guys get treated. They go into a good period, of a few years where things are going well, and then, if it's necessary or when it's necessary, if the cancer starts growing again, we continue the androgen deprivation therapy, but switch the other drugs. So we might add a chemo if we hadn't used before. We might use that Pluvicto, et cetera. So this, as I said, it's not curative, but this is very, very effective. There's a big difference between treating and not treating. And we keep making progress. So thanks, everybody. I think we're going to have a good period of discussion.
Yeah. Do we have any questions from the audience?
Thank you for the presentation, Doctor. But I would like to know, I'm listening to the part about the Black men having the prostate problem more so than other nationalities. But, and you gave the age of 40, I think it was great, 40 to 55, 50. Is there a possibility or would you consider getting tested
earlier Black men, considering they're at higher risk?
I think probably not, because it's just very rare, less than 40. I've treated a lot of prostate cancer. I can maybe think of one case in their 30s, black or white. But I think if guys get started screening at 40, I think we're doing fine.
Okay, so that range is fine.
Yeah.
But the other question, if I may ask, is there a link between the death rate of Black men and not getting tested earlier than 40? Because if in your presentation you indicated that sometimes there are no symptoms, correct? So if we have a Black male who doesn't have any symptoms, and when he goes to his regular doctor's appointments, and if his doctor is not as attentive to ask the questions, and he doesn't necessarily know how to advocate for himself, I mean, it just, that's concerning to me.
Yeah. So
because if it's something there, and I'm having a symptom, but I'm not thinking in that direction of getting tested or asking the doctor. I mean, I just don't see, that's a challenge, isn't it?
For sure. There probably really is a link between less screening and higher death rates. We knew Black guys do have less screening, and they do have higher death rates from prostate cancer. Not all of that increased death is due to less screening, but some of it is.
I know, doctor, that you can't respond specifically to what I'm about to ask, but I've got to put it out there on the table. The weekend that I did a class with African American men regarding prostate cancer was also the weekend that President Biden the notification went out about him having metastasized prostate. And so there was a big concern about, here's the president, have they been monitoring him? I thought after age 70, they didn't have to do this, blah, 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 blah. Could you please clarify what you think happened, because you're a treatment specialist?
Yeah. I mean, of course, I know prostate cancer, I don't know anything about President Biden that, other than that's publicly available. But it seems like he followed the recommended screening, and that, he's, what is he, 81 now, around 81? And he hadn't been screened since he was, since back around when he was 70. So yeah, it gets into like, benefits and harms. Like I don't know how severe his case is. I mean, he has metastatic disease, that's what we know from the press. But there's like a little bit of metastatic disease, and then there's like a lot of metastatic disease. And that, we call that all metastatic, so if he has one spot in a bone and one spot in a lymph node, that's metastatic disease. Or if he just has one, one spot outside the pelvis, that's metastatic prostate cancer. Yeah, so I don't know. It's not publicly available. So, he's getting treated. I don't know what his treatment is. So, if he would have got screened at age 75, they probably would have found something, or at 78. But there could have been downsides to that too. In those President Biden, being, if he got diagnosed with prostate cancer when he was president of the United States, that's going to be really disruptive. He followed what appears to be followed was the typical recommendations. It's a little bit up to interpretation. If maybe he should have been screened a little bit later. If he was as healthy as said he was. But there would have been, if he would have been diagnosed, there would have been downsides too. And he's metastatic, and he may do fine and have his prostate cancer have very little impact on the rest of his life.
The reason I'm asking that is because the majority of men that I've had contact with are in their 70s and 80s.
Yeah.
And they say, the doctors say, oh, you over 70 now, we don't have to do that kind of screening. How do your recommendations get to the medical field?
I don't have a great. I wish I had an answer. I think there's overscreening and underscreening, but I don't think anybody that spends a lot of time thinking about this stuff would say that a really healthy 75-year-old shouldn't be screened. It's more. I guess maybe the way to put it rather than age is life expectancy. If somebody's a really healthy 75-year-old is probably going to live more than 10 years. We kind of set that bar for screening, and you're likely to live more than 10 years or so. A really healthy 75-year-old is probably going to live more than 85. So they probably should be screened. But there's the other side. There's really unhealthy 65-year-olds that may not see 70. So somebody like that, it doesn't make as much sense.
There's an art to medicine.
Yeah. Exactly.
Medicine, sir?
Yes.
Could you be more specific?
That was actually my question. That I thought up ahead of him, ahead of this program. I had to come up with a couple of questions. I was bringing up about President Biden, and my question really is because at the time when he was 70, he would have been a senator or he was vice president of the United States. So even though guidelines maybe say stop screening at age 70, should somebody in that position that is deemed otherwise healthy have continued screening just because of his position?
Screening should take place, to me, regardless of your position.
But it depends on other factors like your health. So just as Dr. Kukowski has said, if you have a 70-year-old that's running marathons, or a 75-year-old or an 80-year-old, maybe it makes sense to keep screening. But if you have a 60-year-old that's on oxygen therapy at home for his advanced COPD, it probably doesn't make sense to screen at that age.
Yeah, there's art to medicine, and the trouble is, good medicine takes time. And, either we don't have the time or we don't put in the time sometimes. It's like to really have, these conversations, we call it informed decision-making. Like you got to have that, to do it right, you got to have that conversation with everybody you're screening for prostate cancer. And it's a bigger question than we have time for here, but that's going to take a long time. And sometimes it just doesn't get done.
All right, we have a few questions from Zoom, but we got one more in the room. Okay.
Okay, speaking of time, I was thinking about the symptoms. I guess I wasn't clear on how symptoms show up in men to kind of lead them to treatment. And then I was thinking about how long does it take for this prostate to develop? Is there a time frame that you could have it in? They say that the men take too long to go and get seen. So is that like years, or is this something that can happen in months, or?
So
Just if you could
usually
speak
it's,
to that.
usually years. So Dr. Ginsburg had in one of his slides that screening detected prostate cancer. I think he listed the range. It tends to be discovered 6 to 13 years earlier. So that kind of gives you some idea about how long it takes to present itself otherwise. Of course, there's a lot of variability. An aggressive case may go from 0 to 60 in 2 years. But indolent cases could never become apparent. But if they become apparent, the symptoms are going to depend where they're causing trouble. So it could be urinary in nature. Like I said, more commonly urinary problems are not prostate cancer, but they can be. Could be urinary in nature, and if it's spread to places, it would cause trouble by wherever it's spread to. Could be back pain. Could be could be trouble with liver. Something like that. It depends where it goes. Yeah, yeah. A real small prostate cancer in the prostate is just never going to cause symptoms.
So would you recommend that they have, I know y'all don't want to hear this guy, would you recommend that they have that anal?
The rectal exam, I think it adds some, yeah. But I just don't want to scare guys away from getting PSA if they think if they get a PSA, they have to have the rectal exam.
Okay, scratch that.
So we do have 3 questions online, and then we will take maybe 1 or 2 from the audience, and then we have to wrap up. But, Dr. Kowski, if you can hang around for a few minutes for those who do have questions, who don't get it answered right now, he'll be around to answer your question. Yep.
All right, this question is from the Zoom. Dr. Kukowski, we know that you mentioned a lot of the factors is societal and socioeconomic. So what are the major determinants? How much of it is connected to diet and physical exercise? What type of food should men be eating to prevent?
So in general, there's getting to be more work of this, and we're appreciating it better. And there's probably more of an impact on development of prostate cancer than on progression of an established prostate cancer. But really, to try to summarize, I or Ginsburg would tell you the same kind of things that a primary care doctor or a cardiologist might say. So that being a lot of plant-based stuff, limited red meat, limited sugars, not the standard American diet for a lot of us.
That's the sad diet.
Yeah. I mean, if you know what you're doing, you can cook better, and make it more interesting, but that just, we're really seeing that's what makes an impact is mostly plant-based, low, simple carbohydrates, low red meat.
All right, we do have time for just one more from
From
Zoom. Yep, and then afterwards, if anybody has any questions, you can feel free to
I'm
ask.
gonna try to put both of these in one question. One of the questions was, does Karmanos Cancer Institute offer free PSA testing and/or prostate exams in the Metro Detroit area? And, well, I can't really put this one in. So, the free examinations.
Yeah, well, for on an everyday basis, I think the answer is no. Maybe we should. But, then again, there can be some downsides that come with PSA screening, like overtreatment. So that's probably why it hasn't happened. But, we have, we were running some limited scale screening programs. One of that was a research study, but the basic answer is no. For some for good reasons, maybe not as all good reasons, but.
I did have one more. Is that fine? This question came from my dad. He's on the Zoom as well. Because my dad is a prostate cancer survivor. He had his prostate removed in 2012 and then had a needle biopsy, which was pretty barbaric. It caused him to become septic, and then he had radiation, and it's now returning in 2025. So he's trying to figure out, like, is this the best way because he has a PET scan now coming August 5th. So he's just trying to figure it out because he had the prostate, how you say it? Prostatectomy? Prostate?
Prostatectomy.
Yeah, prostatectomy in 2012. Then all of that transpired, but now PSA levels are rising and they're trying to figure things out. And it was done at Karmanos as well. So just trying to get some direction there.
Kind of hard to give that much direction to, a specific case, without knowing your dad, meeting them, or, knowing all the information. But at surface level, it sounds like reasonable things are being done, but I'd encourage them to, have doctors that are experienced in prostate cancer. Second opinion, if that puts things at rest for them or gives them another idea. Most cases of prostate cancer aren't moving so fast that you can't get somebody else to look at things.
All right, that's all for questions today. Thank you again, Dr. Gukowski, for your time and your expertise that you lended to us today, to the community. And if you're gonna hang around for some more questions.
And then we have Lassie, who has a few more instructions before we close out.
Okay, that was a lot, but definitely very informative. So let's take a moment to reflect on what you have learned. We have a few quick questions to help you think about the key takeaways from today's session. For those of you joining us in person, please take out the highlight yellow colored paper labeled post-knowledge questions. One of our COE members will be coming around to collect them. So you can take a minute to just answer those questions. And for the participants joining us on Zoom, a poll will be launched on your screen in just a moment with the same 3 questions. So please take a minute to answer them using your device. 6 questions, I'm sorry. Yes. You mean as a replay? Ali?
Yeah, we'll get the recording as soon as we do the code.
I only wrote 3 of the questions. If you don't like them, it was Ginsburg's question.
Can I make a comment? So as a general internist, a primary care physician for almost 40 years, I had 100, 200 plus men have prostate cancer. I had only about 3 that I know of that died from their prostate cancer. So while it's a very common malignancy, most cases do not cause death. They are discovered at autopsy incidentally sometimes, and doctors then get sued because they didn't diagnose, even though it was not causing them any problem. But just to put men's minds at ease.
Okay. All right, so let's review the question. Most men should begin screening for prostate cancer at age 45 to 50. True. Oh, good, good, good. Men at higher risk for prostate cancer, such as African American gentlemen, should start screening at age 40 to 45. True. Very good. When screening for prostate cancer, PSA should be checked every. Okay, we said two, doctor. He said two. He said two. Okay.
It's cheap. It wouldn't hurt you to have it every year.
Okay. Okay. All cases of prostate cancer need to be treated.
No, false.
False. Okay. And for the two on the back? False. Okay. Erectile dysfunction is a possible side effect of treatment for localized prostate cancer.
True.
True, very good. The most common type of medicine for prostate cancer is? Yes.
Is what?
Androgen deprivation therapy, is that right? Okay. All right, thank you for your participation. Okay, thank you for your participation. Before we go through the answers, I want to remind everyone to complete the evaluation included in the packet that was found on your chair.
All right. Well, thank you all so much for being here with us tonight, both those who joined us in person and online. Yup, another round of applause for Dr. Kowski. And especially, so yeah, thanks to Dr. Kowski, thanks to Dr. Ginsburg for his portion of the slides, who unfortunately couldn't be here with us. And then thank you to our wonderful moderators, Lance, Steve, and Lassie, for helping guide such a thoughtful and engaging discussion. And we also want to recognize the Detroit Public Library for their ongoing partnership, our wonderful community partners. If you didn't get the chance, they're all in the back, so please feel free to stop and see what they have. And for Global LT for providing interpretation services in both Spanish and Arabic. The conversations we have here don't end when the event does. They carry forward through continued collaboration, action, and community engagement. And we hope you'll stay connected and join us for our future events. We have one coming up in September, one in October, and one in November. So please be sure to register for those if you're interested. And from all of us at the community, at the Office of Community Outreach and Engagement, we thank you and we hope you have a wonderful evening.